Good afternoon, and thanks for joining me. You may remember some weeks ago I had a meeting with Mr. Ill from NAPE and some of his paramedics. So I wanted to bring you an update today based on some of the information that came to light as a result of that meeting. Before I begin in detail, I would like to say that, our paramedics are crucial. The service they provide is valuable, and that we all need to work together to help fix the challenges that we have at the moment, because government, the RHA, or the paramedics alone can't do that. We need a reliable, safe, and high-quality ambulance system. We've seen that they have been under increasing pressure for some time, and while the pandemic's not the only cause, the impacts of the pandemic have actually been felt widely across the healthcare system. So our paramedics have been challenged by increased demand, and they've been held up by delays in the emergency room with offloading, and this affects response times. So while as a government and the regional health authorities have made prior investments, it's obvious that we need to take some further steps to remedy this. So just to give you some background before I go any further, I'd like to give you a brief overview of some of the statistics that we had that have caused me some concern. These are Eastern Health data, and they're from a system called CAD, which is Computer Assisted Dispatch. The first slide here reflects demand and offload delays. So from Eastern Health, the offload delays are really only being experienced at the two metro facilities. The call demand through the rest of the system is nowhere near as high as in St. John's. We have 15 metro ambulances out of a total of 179 frontline rigs across the province. That's 8.4% of the ambulances, but they perform 47.5%, 27,000 calls per year of an emergency nature. The workload is skewed. Slide 2 tells us about mutual aid. It tells us that we're using mutual aid or the assistance of other non-Eastern Health ambulances to respond to the increasing number. So even if there's not an Eastern Health rig available, there is still a response and help will come. But the increased need for these alternative measures is due directly to the rising number of calls and the delays in offload. So the third slide really tells the story of the effect. So since December of 2020, the total call demand has gone up by 13.6%, and the offload delays have increased by just over 28%. The offload delays remain static as a proportion of the call demand, but the current response times are longer than we want to see. It's important, however, to note that these are metro biased. The calls in metro are responded to more quickly than the calls in rural St. John's and rural Eastern Health. The offload delays are a factor in 17% of the transports. So what that 90th percentile means is that a figure there is achieved in 90% of the calls. So that is time from the call to arrival on scene. And this shows the time frame from when we introduced what we call non-medical transport into Metro in April of 2019. That's kind of like the elective inter-facility transfers, and that takes a significant number of calls out of the system. Also in the first 18 months of the program, advanced care paramedics actually treated a significant number of people in their home. 883 people are enrolled in the palliative care program, and 81% of those were seen by an ACP, treated at home, and did not require transportation to the emergency department. And that's another 1,000 calls out of the system. But despite that, the demand increased. In March of 2020, we've added an ACP clinical response unit, adding community paramedicine onto the personal and long-term care home sector to try and reduce the number of transportations needed from there. So whilst these numbers are certainly worrying and need a response, the one message at the end of this is if you call an ambulance, one will come. If you need help, call, and there will be a response. But as I stated at the beginning, this data is concerning. So this section of my little presentation is around some further steps towards remedying the difficulties. So we're going to put in extra resources. So in terms specifically of ambulances and positions, you may remember recently we announced 2 new rigs for Eastern Health, and Eastern Health are currently still staffing up to run those. That's another 16 full-time paramedics, and Eastern Health has not yet completed the recruitment for that. On top of that, in the light of these figures, I have directed Eastern Health to get a 3rd ambulance, and that will need an additional 8.9 paramedics to address the current peak of activity. So that's a total of 3 new rigs over the course of the last couple of months. In addition to this, Eastern Health has put in some additional room, some space, to receive incoming patients at the Health Science Centre and minimize the delays to those crews who can then go back out and be available to be dispatched to 911 calls. So in total, Eastern Health will have 24.9 new total full-time permanent positions working in paramedicine. The other thing we heard very clearly, and it was hard to hear and difficult, was around the mental health challenges that paramedics face. They are first responders and see things that really few people could or should have to deal with. Whilst we do have a suite of e-mental health services available at the moment, things like Doorways, which we've expanded, things like Channel and the Warm Line. In addition to that, though, we heard very clearly that the needs of paramedics and first responders are different in terms of who they can talk to. So we're working with Eastern Health, with NAPE, and with other organizations such as Channel to find a dedicated line or dedicated access for paramedics and first responders to seek counseling that's suited and suitable for them. They work 24/7, and we would like to have that kind of response available for them should they need it 24/7. So that's a work in progress, and indeed I understand my staff and NAPE will be meeting tomorrow, and that will be one of the topics of discussion. And that leads me on to the last piece, where the consultation here, I think, with paramedics has been crucial. Hearing their stories firsthand has certainly been a bit of an eye-opener for some of us, and I think they're to be praised for putting themselves out there again to do that. More long-term, we need to look at how many paramedics we need, and we need HR planning. We have, over the years, recently invested in recruitment and retention initiatives. As recently as this morning, I was speaking to Minister Osborne. He is the minister responsible for the College of the North Atlantic, about how we can further increase paramedic training in the province. There's been a recognition also of advanced care paramedics and the utility they bring and the value they bring. And so in this regard, we've conducted a review, because by and large, every advanced care paramedic we train locally is a primary care paramedic we've taken out of the system to advance their level of training. So currently we have 63 PCP, primary care paramedic seats in the province, over 4 sites. We're looking to see what number makes sense in terms of increasing that. Currently, we have 24 advanced care paramedics in 2 classes in training. We're going to increase the class size now from 12 to 24, starting in the new year. In February of 2020, we announced funding also to support enhanced programming for the September intake of that year for other healthcare providers as well. So with the practical nurse and personal care programs, we've seen significant increases, which are now permanent, in the seats for those. So we've increased the practical nurse program offering by 116 seats, pretty well 40%. We've increased offerings in location and number for PCAs So there's an increase of 96 seats. These graduates will be coming on stream over the course of this fall and into December. And you've probably already seen some of the health authorities with an active advertising campaign out to recruit these. We're also, just so nobody feels left out, working towards a similar plan for nurses, and we're working with the Department of Education, Memorial, the regional health authorities, and the RNU to see what a reasonably maximized training capacity is for Bachelor of Nursing in an attempt to see if we can home grow our own to meet the demand rather than having to recruit from outside. So again, with paramedicine, significant work has been done, but this data sends us a strong message that we need to keep on this and maybe do more. We feel we're on the correct path to address these issues. I spoke with Mr. Earl this morning, had a very good conversation, and I thanked him for his input and his health. And I look forward to continuing to work well with NAPE directly and through the department. We are not alone in this surge for demand. This is happening across the continent. It's happening across the country. And these factors that we experience here are similar to those that you would see in Edmonton or Toronto. Apart from these measures, the committee structure that we struck with NAPE is active. As I said, it meets tomorrow. I look forward to see what other contributions they will bring. These problems didn't arise overnight, and they won't be fixed overnight. But I think this is another step in the right direction. I've had discussions with the Premier, and he too is very committed to the topic and wants to focus on building up our healthcare system to meet the demands of today. The discussions that we're having are around how can we train as many healthcare providers across the board in the specialties, the disciplines that we need, and do it in a way that makes sense and we have the capacity to do. So we're actively working on elements of physician recruitment and the need for a human resource plan in this area, and I look forward to talking to you more directly about these particular topics in the next coming days. So just to close on the paramedicine piece, if you're anywhere in the province and you feel you're unwell and need an ambulance, call and help will come. So with that, I'll hand this over to Leslie for moderating of the media questions. Thank you, Leslie.
Thank you, Minister. We have one reporter in person and 3 joining by phone. The first round of the questions will be 1 question and 1 follow-up. This will be followed by single questions until approximately 3:45. Our first questions are from Henrika Wilhelm with CBC. Please go ahead and make your way to the mic.
So you said that you spoke to Mr. Earl about all this and that you had discussions about especially the HR and the recruitment. So you said one more ambulance is going to be in place. Is this for now the plan that's in place, or are you planning on adding more in the near future?
Just to correct the record, I spoke with Mr. Earl this morning. The substance of HR and those kind of discussions is much more of a long-term thing. It's happened before and will happen again tomorrow. The 3 new ambulances that we announced, i.e. the 1 today and the 2 from a few weeks ago, those are permanent additions. I think one of the challenges is when you have 179 rigs, but only 8.4% of them are doing 50% of the work, one may have to look at other alternatives as well. And certainly those are things that I would be interested in hearing the paramedics' views on.
Mm-hmm. Mr. Earl has also said that one of the problems is the offload delay room that you addressed earlier, that there would be one paramedic taking care of all the people coming in, and that's not feasible. Have you been speaking with him about this?
That will be on the agenda for tomorrow's meeting. Certainly, we've spoken with the staff in Eastern Health, because this is really an Eastern Health issue, and we've spoken about whether paramedics or paramedics with LPNs or RNs should be the sort of staff that support the handover room. So those are discussions still underway. They've certainly identified some staff, but I think it's fine-tuning it.
We will now go to the phone. Our next questions are from Jody Cook with NTV. Please go ahead.
Good afternoon. So you've identified the concerns that exist, or some of them, with human resources for ambulatory care and paramedicine. Once these patients arrive at hospital, we still have some of these backlogs as indicated. What are you doing for the ongoing issues with the crisis with doctor shortages? And we've heard that the NLMA has been calling for this to be addressed. So is this a cart ahead of the horse scenario? How are all these working parts going to work together?
Well, certainly the NLMA have been quite vocal about the need for physicians in general. Our focus today has been on pre-hospital care and getting people to the emergency room. As I said before, we have a short, medium and long-term approach to physician resource planning. And as I also said today, I'm looking to make some announcements about some of those elements in the coming days. The short-term approach for access to primary care is very much an operational thing, and we've been working with each of the RHAs to try and figure out, which doctor goes to what clinic or what nurse practitioner or what role virtual care has there. So those are very active discussions. It's the bit in the middle until the health accord comes out that we will be talking about next.
You had a chance to look at the breakdown of where some of the calls are coming from. Do you have a chance to do an audit on those calls as to which ones might not necessarily need an ambulance, whether it might need some other sort of approach within the healthcare system, just maybe free up an ambulance for a car accident or trauma or that sort of thing?
Yes, certainly one of the kind of low-hanging fruit here, and it's worked in Central and Western and has been recently reintroduced rather into Eastern Health, is the idea of the non-emergent patient transfer. Significant proportion of all ambulance duties involve moving patients from planned trips for dialysis or for investigations from one facility to another. Eastern Health has introduced what they call a non-medical transport program, and that's started to have effect. Certainly as we get a range of pre-hospital or out-of-hospital practitioners available, community PCPs and ACPs in Metro have demonstrated their real value in being able to visit on a call, treat and leave according to their skill set. And we'd love to expand on that, which is why we've brought back the advanced care paramedicine program to the province. We taught it in Qatar for years, and we never even taught it here. We had to send people out to PEI, I think, was the favorite place to go. So again, those are steps in the right direction. One of the challenges here is, for example, it takes 18 months to 2 years to convert a PCP into an ACP, and it takes a similar length of time to train a PCP. So the decisions we made last year still haven't come to bear fruit because of the lag between making the decision and putting it in place. These LPNs, for example, and PCAs who will be graduating over the next couple of months, those decisions were made in the beginning of 2020.
Our next questions are from Peter Jackson with the Telegram. Please go ahead.
Hi, good afternoon. You mentioned with the nurses, one of the biggest issues with nurses is that there are a lot of casual nurses. They don't want to take a permanent position in the current environment. How will increased training help with that?
Well, on a very simplistic level, if there's more people to ask, you have more chances of someone saying yes on a given day. But we certainly are aware that this casualization of the workforce is a challenge for us and indeed for everywhere. It's certainly not unique to this province. We've seen my colleagues across the country in Ontario and Alberta struggle with very similar things. And one of the discussions that we've had with Mr. Earl and indeed with Ms. Coffey from the RNU is, what is it that's driving this, and is there some recruitment tool we can use that might make that less likely as a career choice? So we don't have the answers, but we're certainly aware of the problem.
Okay, thank you. And a little while later, you talked about because of the difference in workload between rural areas and the metro area, you may be looking at other alternatives. Would that include taking ambulance service away from other communities?
No, we have a policy that's well established and predates me. It goes back maybe 20 years or more of what's called mutual aid. And certainly in rural areas, if there's a rural ambulance in Community A that's deployed and busy and another call comes from Community A, an ambulance operator kind of over the boundary will come and help out. We have fire departments who are very good. In actual fact, I think Pooch Cove set the record. They can get there in 3 minutes from the fire department, where the ambulance takes maybe 7 or 8 or longer, depending on where they're located when the call comes in. So, I mean, we've used private companies to provide cover for that halo of communities around the edge of core metro, and those are long-established practices.
Thank you.
Our next questions are from Brian Callahan with VOCM. Please go ahead.
Good afternoon, Minister. I'm wondering, you mentioned earlier one of the statistics was the demand had still increased. Calls had still increased despite losing almost 900 palliative care patient calls. Is that accurate? And again, how staggering is that? I mean, can you just dig a little bit deeper into how that could be such a disparity? You gain, but you lose so much.
Yeah, it really is an interesting conundrum. We have removed, as you say, about 900 calls from the palliative care program. We have the elective transfer system, which could take out a couple of thousand out of the system, and yet the calls still increase. We're looking at root causes of that. Again, I don't have an answer as to what's driving people there. There's certainly a lot of anecdotes about difficulties accessing primary care, for example, out of hours. But the information from Eastern Health certainly has been, it's not been kind of family medicine clinic kind of patients that are turning up in larger numbers. It's more the sick, what's called CTAS-3 group of people who need hospital care. So again, we're not quite sure, is that an effect of COVID or what else is necessarily going on, and that will take some time to unravel. Thank you.
And you said 3 or 4 times there that, at the end of a statement that, an ambulance will come, one will come. I guess the point of all of this is, sure it will, but it's eventually, not, nobody knows when. And it's the length of time, I think, that's causing those people all the consternation. So, when you say one will come, certainly you appreciate that that's the problem, right? But when?
Well, the current data shows for Metro that for the core of Metro, the response time is just over 10 minutes. The standard for an urban call like that is 9. So there's scope for improvement there. The more rural areas where the computer-assisted dispatch system is in place, because that's the only way we easily get data, is that that's hovering around the 19-minute mark, and 15 minutes is kind of the target that we would use. One of the things I have asked Eastern Health to do is to provide me now with monthly statistics on the Priority 1 calls, and the regional health authorities that don't use computer-aided dispatch, I have instructed them to provide me with quarterly reports, because that's a manual data pull off paper records. And the final piece of that is that we want to roll out computer-aided dispatch across the province into each of the RHAs. And we've had some discussions at an operational level with Central Health, for example, about starting there.
Okay, thank you.
I will now go back through all registered media for single questions until approximately 3:45. Our next questions are from Henrika Wilhelm with CBC. Please go ahead.
You just spoke of statistics that you've been asking for. I'm just wondering, could you give us an idea, because there's been so much discussion about red alerts, and Jerry Earle has always said there's been red alerts over the weekend. Could you give us an idea of how frequent red alerts have been happening in the past month?
We've shifted our focus in line with both the POMAX reports and all of the 3 Fitch reports to talking about response time. Red alerts is a very metro-centred term. It simply means that an Eastern Health ambulance will not be what turns up to get you. It doesn't say anything about whether St John's Regional Fire Department would be the first responder or whether a private company like Fewers or Freaks will turn up to get you. the fact of the case are an ambulance will come. We're aiming at the response time. We want that to be as near or as low as is possible. One of the other features is this concept of dynamic dispatching. We don't need ambulances in bases anymore. And so we've got GPS locators on every ambulance. So we can have ambulances kind of patrolling an area if it's a quiet time, or alternatively, we can have them, the nearest one dispatched rather than one that's nominally from a depot or a base nearby. So those are all operational issues that the Department of Paramedicine within Eastern Health is working on here. But again, they're applicable in other slightly smaller urban areas such as Gander, Grand Falls, Corner Brook, that kind of thing.
Our next questions are from Jody Cook with NTV. Please go ahead.
Hi, forgive me, Minister. I just wondered if I could ask a COVID-related question because we do see our 2 new deaths in the update today. Is there anything that you wanted to add or provide us with information on today's COVID numbers?
No, the general trend is in the right direction and the number of active cases continues to slow down. Obviously, we send our condolences to the families of those concerned. It's a difficult time, and we have said quite clearly from the beginning that, you know, personal health information remains personal, and I'm not going to be the one to let it out there.
Our next questions are from Peter Jackson with The Telegram. Please go ahead.
Oh, hi. Sorry about that. The NLMA said a week or so ago that they looked for a long-term plan through an access request. They couldn't find one. I noticed today you said short, medium, long-term approach to solving healthcare problems. Is there something written down that we can actually see where this province is headed?
There's lots of things written down, Peter. I mean, the long-term plan is essentially going to be the health accord, and that isn't written yet except in draft. But certainly that will be presented to myself and to the Premier and Cabinet, and we will go through that and do our due diligence, and that will be our roadmap. That's quite clearly stated. This is a way to shape the next 10 years in healthcare. The short-term, immediate stuff is all operational with the regional health authorities. There's material there about, clinics, drop-in clinics, collaborative care clinics. The kind of intermediate stuff is that grey area. The NLMA, for example, go to every meeting of the steering committee of the task force. The NLMA are engaged in active negotiations at the moment, and that's kind of in a box. But we have staff talking to NLMA staff outside of negotiations on bi-weekly basis, every second day. So the material exists. It's just not in a big binder with the plan written on it in red letters.
Thank you.
Given the time, this will be our final question. Our next question is from Brian Callahan with VOCM. Please go ahead.
Hi, thanks. I'll be brief. Mr. We're asked about the bigger picture. Doctors, we have nurses, some shortages in Central and elsewhere in the province. So, this is just about the paramedicine piece today. But, I know you've resisted using the crisis, but given everything across the sector, beds, everything, what is it if it's a crisis? What word would you use? I mean, is there political reason you don't use that word, or is there a better word?
There was a program on the radio in the UK when I was a child where you had to answer a question for a minute. The contestants had to avoid using the words yes or no. I'm not going to have words put in my mouth. I think the issue is very plain that we have challenges in the healthcare system in multiple areas, and we have approaches to address them. The fact of the case are, for better or worse, we are no worse off than a lot of other jurisdictions and better off than some. Not that that's any comfort to anybody, and not that's a cause for complacency at all. But the facts are that we have a lot of policy work that would have been done by now had the 260-odd people in the Department of Health and the multiple thousands of people working in the regional health authorities not been seized with COVID. We were in a position to make some policy work announcements well into the summer had that work not been put on one side to deal with the end of the third wave and the beginning of the fourth wave and the reopening of the province. So I would argue that You're right, we do have significant problems across a lot of healthcare areas, but we also have a lot of effort going into fixing those.
Thank you.
Thank you, everyone. Minister, do you have any final comments today?
No, again, I want to thank Mr. Earl and his team of paramedics at NAPE for coming forward and continuing the dialogue. I also want to again close by saying that if you feel unwell and you need an ambulance, one will come, and there are further announcements to be made in the coming days and weeks, and I look forward to sharing those with you. Thank you very much for your time.
Thank you, Minister. Stay safe, everyone. Take care of yourselves and each other, and enjoy the rest of your day.